Good afternoon, everybody. Thank you very much for tuning in today to listen to a talk on the use of MRI in the modern management of prostate cancer. The emphasis is going to be very much on the use of the technology in current practice rather than the technology itself. Here are my disclosures updated. Now, we know that as a patient progresses from the point of where there is suspected cancer to death can take 15 to 20 years. And the UK figures for how many trust biopsies are performed every year are on the left-hand side between 60 and 80,000, and then about 11,000 deaths per year. Now, clearly there are several groups of patients one can identify, from suspected disease to known disease to biochemical recurrence and advanced disease. And within each of these categories there are groups of patients such as low risk, intermediate and high risk patients, in patients with known cancers, and then in advanced, often metastatic disease, you have the oligometastatic groups, the polymetastatic groups, castrate naive, castrate resistant groups, etc. And there isn't enough time to cover the entire spectrum today. So I just want to focus on three areas where I think MR imaging can really make an impact. And let's start with the first one, which is in suspected disease. Now, when there is an elevated suspicion of prostate cancer, usually on the basis of a rising PSA, with or without a abnormal DRE, or in a patient with a negative trust biopsy, we know that up to 50% of these patients, depending on the group, will have a clinically significant cancer. So the role of MRI here is to identify the location of a clinically suspicious lesion to enable a targeted biopsy. The important thing to remember is that we need to prevent overdiagnosis of clinically insignificant disease and also to improve risk stratifications. Now, currently the imaging is not incorporated into the biopsy paradigm. Probably the only cancer where this occurs, but as radiologists we make a lot of claims in this area. So we claim that MRI has the performance characteristics to help manage patients with suspected or proven disease, and it's not only radiologists, it's the EUA, the NCCN, and even NICE agrees that MRI has a role. Our ability to rule in and rule out disease depends on the multiparametric approach, and we will discuss this in a second. But image quality, the reading system, and the reporter's expertise are also very strongly important for this for this success. Now, clearly the depiction ability depends on the anatomical location of the lesion. It depends how big it is, how aggressive it is. And the clinical utility, which is something quite different, of course, is an interdependent function that depends on the target disease prevalence and the test performance, and we will discuss this in a moment. Okay, so if we are having a urological discussion and about who should get an MRI, the first thing we should say is not everybody should get an MRI. Only those who are likely to benefit, take into account their life expectancy and comorbidities, and that just makes sense. So who are these patients? Well, if you look at the EUA guidelines in 2015, the EUA guidelines very clearly state that if there's a continued clinical suspicion of prostate cancer despite negative trust biopsies previously, then they recommend an MRI, and then proceeding from that point, which I think all of us would agree with today. And in fact, NICE says the same thing in 2014, but goes a bit further. It says do not offer a biopsy if the MRI is negative unless other high-risk factors are present, such as high-grade PIN, an abnormal DRE, or ASAP on a previous histology. Now, the London Cancer Alliance, which has now been disbanded, said that in fact there are 4 situations in which an MRI would be required before a first biopsy. Now, and when are these? Well, if there was a palpable abnormality on a DRE, if the PSA was greater than 10, if there's a high clinical suspicion, and the patient is fit for radical treatment. Now, if you look at these 2 factors, there's a palpable abnormality and the PSA is greater than 10, that is a form of data enrichment. Now, before we talk about data enrichment, I just wanted to take you a bit further about what a previous guideline said. The current guideline from an insurer in the UK, Bupa, and they're quite different to the other 2 guidelines that I mentioned. They said, consider a multiparametric MRI for all men destined for a prostate biopsy, and the appropriate biopsy strategy depending on the MRI findings. So a slightly nuanced way of looking at it, and again we will come back to this theme of having the appropriate biopsy strategy depending on the MRI finding. Now, so what we're really saying is that we need to enrich the population using PSA metrics or risk calculators to be able to get a good MRI together. So let's take a look at this guy here, who is a general practitioner. And he's a general practitioner who has a raised PSA, a family history, normal DRE, has a volume of 61 ml. So, would you advise biopsy, a trust biopsy, on the basis of this? Now, if you look at the all cancer detection risk, it's 10%. A significant cancer detection risk of 2%. Well, if you look at the recommendations, this patient doesn't qualify for a biopsy at this stage. And if you look at the Rotterdam risk calculator, these risks were devised on the basis of a sextant biopsy but have been multiply validated using 10 to 18 core biopsy. So he really shouldn't get an MRI. He shouldn't get a biopsy. What would you do? Would you advise trust biopsy because this is a standard of care? Would you say this is borderline, therefore get an MRI and then decide? Would you say, well, he doesn't need a biopsy and he doesn't need an MRI because he doesn't even qualify? These are difficult questions. So, in fact, we considered this to be a borderline case, and we did an MRI, and we found a lesion, a small 5 mm lesion at the apex of the prostate gland at the junction of the transition zone and the peripheral zone, an area that will clearly be missed by a standard trust biopsy. Then now we got ourselves into trouble, because how do you biopsy this lesion? Well, clearly we've gone down this route of performing an MRI. We now need to do a biopsy, but what kind of biopsy should we obtain? Should we be doing a targeted biopsy? In other words, 3 to 4 cores compared to 12 cores from a trust biopsy. And if we did that, the advantages would be improved risk stratification, improved diagnosis of clinically significant disease, fewer biopsies, and a reduction in the number of patients with non-significant disease being diagnosed. So that may be one way to go. But alternatively, one could do a saturation biopsy. So the saturation biopsy can be performed transrectally or transperineally with or without image guidance, But we know that you acquire many more cores, it is systematic, and you do improve the diagnosis of clinically significant disease, but you acquire a lot of biopsies. If you wanted to take this to the extreme, you could do a template biopsy transperineally, acquiring more than 30 cores, and then you'd be sure you wouldn't miss it. So in this particular patient coming back again, what will be the best strategy? Well, I don't really know which is the best strategy, but I know what most people think. Most people would say you should do a truss biopsy plus a targeted biopsy, and you do the truss biopsy just to be sure. In other words, if you had a lesion like this, a large anterior tumor in the transition zone, you would put some needles through that, and that will be your targeted cores, and then you would put your standard cores through the peripheral zone and rest of the prostate gland just to be sure. And that means that the pathway would work like this. So after the diagnostic MRI, you would do a systematic truss biopsy plus targeted biopsies, and if it was negative and you were still very suspicious, you would do a full template or a saturation biopsy, and then you would triage the patients accordingly. Now, the important question you really need to ask is, what do these additional cores give you in different populations? Now, it turns out that if you look at the paper by Siddiqui, which was published in JAMA last year, well over 1,000 patients, you would need to do 18 combined biopsies to detect one additional significant cancer. But in the meantime, you will have overdiagnosed 3.7 low-risk cancers. In the first biopsy cohort, you would have to perform nearly 15 combined biopsies to detect one additional significant cancer using the combined approach. But you will also end up diagnosing about 2.3 low-risk cancers, which you really don't want to do. Clearly, this is a value judgment that has to be decided within a multidisciplinary team. Bottom line, if you have a lesion, then you need to have available and use biopsy methods that minimize overdiagnosis of insignificant disease, such as not only sparse type 3+3, but also other abnormalities that require longer-term follow-up, such as PIN and ASAP. But also, you need to improve risk stratification. And for that, you really need to tool up, and I suppose that's the first lesson. So what are these tools? Well, for a lesion like this, anteriorly towards the peripheral zone, likely to get missed on a truss biopsy, clearly you need to target the biopsy. In this particular instance, the targeting was done transrectally in an MRI scanner with targeted biopsies through the lesion. But on the other hand, a patient like this, who has diffuse disease in the left peripheral zone, where it more or less looks the same, well, why do you need to target this lesion? Well, you probably don't. A standard spread of 12 core truss biopsies should sample this adequately, and you can see that there is Gleason 3+3 disease and a little bit of high-grade PIN found bilaterally, which is interesting. Now, let's take a look at this patient here. So this is a patient who had a PSA of 5.3 in December 2008, had small foci of 3+3 plus, prostatitis, and he was treated with active surveillance and antibiotics. Now he goes on to active surveillance. There is a little lesion here. In 2008, we had no way of biopsying this lesion. And here we are a year later, and what we notice is the PSA has gone up, the lesion is a little larger. The diffusion sequence shows a lowering apparent diffusion coefficient. So this is a lesion that's progressing. This is a lesion that we need to do something about. The question is, what can we actually do for this patient? And how are we going to biopsy? So, in 2008, what could we have done? A trust biopsy, again. Hope you missed it. Targeted biopsies, 3 to 4 cores, well, not available in 2009. Saturation biopsies, Templar biopsies, systematic and trust biopsies. In fact, what we did was we did a perineal template plus targeted biopsies through that area. Now, many of you will ask why we took so many biopsies when we had an obvious target. Well, we did that because of the next step in this patient's management. The patient wanted to be treated with HIFU if that turned out to be a cancer. So, the imaging and the biopsy should be aligned with the management care pathway of this particular patient. So, if we were going to do a prostatectomy, then he may not need a biopsy at all. But since he wanted to undergo ablation, we had to make sure that there was no other significant disease elsewhere. He's been followed up for 7 years now, and he's got a small recurrence adjacent to this treated area, which he's having a rebiopsy for. So another lesson to learn is that you need to have biopsy methods that not only reduce overdiagnosis, improve risk stratification, but something that also directs the management, and that means tooling up. So the management pathway now looks like this. So if you have a diffuse abnormality on an MRI scan, then you can do a standard trust biopsy. If you have a focal lesion that is suspicious on a MRI scan, then a targeted biopsy is what you should perform if you want to decrease overdiagnosis, and you will obtain, another benefit of that would be fewer targeted biopsies per patient. The question that really one should ask is, what do we do about patients who have a negative MRI? If you have a negative MRI, some people would say you should biopsy them anyway, because they are clinically significant. They are clinically suspicious. Well, we're not sure about this anymore. If you have a negative MRI, we suggest clinical follow-up and reevaluation, periodic reevaluation of the patient's risk. That way, we reduce the total number of patients undergoing biopsy. Now, the question is then raised, well, how many cancers do you miss? And what happens to these? How many high-risk cancers are you missing? Well, this was looked at by a recent study, looking at over 800 patients, and then looking to see how many cancers reveal themselves within 2 years of a negative MRI. Now, as you would expect, there were high-risk cancer patients, 18 in 830, so a small number of high-risk cancers. The majority of those, when followed up, were detected within 1 year. 72% were detected within 1 year, and 83% of these were organ confined. And about a quarter of these patients had a normal MRI even in retrospect. So it looks as though you should be able to follow patients clinically who have a negative MRI, but you certainly cannot discharge them. That way you get the additional benefit of reducing the number of patients undergoing biopsy. Finally, we need to think about whether the MRI strategy in fact improves the effectiveness in selecting patients who require radical treatment. I don't think we can be completely certain, but there is some very encouraging data that it can improve the effectiveness of the pathway. So if you look at this study that was published last year, what you see is that patients at quite high risk were randomized to having a TRUST first or an MRI first. If the TRUST was negative, then they had an MRI, and then they had biopsies, saturations or TRUST biopsies, depending on what was found on the TRUST side, and here is what happened to the patients on the MRI side. What you notice is that a definitive diagnosis leading to a treatment decision was made on the MRI side in one step. If you look at the TRUST side, you'll see that you required 2 steps before you were able to decide what the management plan was. In other words, the MRI in the diagnostic pathway improves risk stratification of patients who are diagnosed. It reduces the overdiagnosis of PIN, ASAP, the sparse type 3+3, which means you need less patients, you need to follow less patients. It reduces the time to reach a definitive diagnosis and to start management, and in fact it turns out that this whole enterprise is cost neutral depending on the model that you see. So really quite interesting data, very encouraging for the use of imaging in this patient group. I'd be happy to take any questions at this stage. Thank you very much for those questions. We can now continue. The next topic I wanted to talk to you about was the use of multiparametric MRI in a low-risk disease, specifically the place of MRI in active surveillance. Now, we know that patients who have low-risk disease, there is a substantial proportion of these patients have higher grade disease on prostatectomy. In other words, these patients are misclassified. I just wanted to show you here a couple of large series looking at prostatectomy specimens in patients who were otherwise candidates for low-risk disease. And interestingly, you'll see that their TRUST biopsy cores were 10 to 12, so exactly what we'd expect in the modern era. And if you look at the organ confinement rates for these patients, you can see out of these 7,000 patients, about 80% were organ confined. In other words, 20% weren't organ confined. And the prevalence of higher risk disease, intermediate and high risk disease, you can see is about 20 to 30%. So patients who come along for active surveillance do harbor higher risk disease, and in fact that can be in up to 30 or 40% of patients. So the role of imaging is to truly confirm that low risk disease is present, so as to allow active surveillance to be undertaken and so reduce overtreatment. But the role is also to identify non-low risk disease to enable repeat biopsy and appropriate triage. So how should you look at what can MRI do for these patients? Well, MRI can help better characterize patients before active surveillance begins, because it helps to reduce the initial inclusion of patients with unfavorable pathology. It can help to identify other subgroups that would be suitable for active surveillance, such as slightly larger volume, Gleason 3+3 disease, some smaller volume 3+4 disease, slightly raised PSA, that sort of thing. But MRI can go much further. It can help to identify triggers for definitive therapy during active surveillance. And this is what I wanted to talk to you about next. Now, it turns out that there have been a number of studies looking at MRI features and how they predict adverse pathology in patients who are otherwise have features that suggest that they might be suitable for active surveillance. And it turns out that anything on the MRI that suggests that something bad is going on predicts for adverse pathology and or outcomes. So larger lesions, higher PIRADS allocation scores, lower ADC values, the presence of a mass, the presence of multiple masses, etc., all predict in univariate or multivariate analysis an adverse pathological outcome on a repeat biopsy or at prostatectomy. And I just wanted to show you some data that. So here is a paper that was published last year from the Royal Marsden looking at just the ADC value in patients who are undergoing multiparametric MRI before active surveillance. What you can see is that if you look at the right-hand graph, you can see that that is the treatment-free treatment-free survival of patients. And essentially what this shows is that if your ADC value is less than 1,000, then you do worse than if your ADC is above 1,000 in terms of the instigation of treatment. So you'll see that if you had an ADC less than 1,000, your median time to treatment would be about 2 years. If you had an ADC greater than 1,000, then your median time for treatment would be about 8 years. Very interesting data. Our data is somewhat similar. Here is data that we presented at the EUA a few months ago. We took about 150 patients on active surveillance, did multiparametric MRI, and we've been following them since 2008. And we looked at the observations at the baseline and how it predicted treatment-free survival. And we did this for 2 readers with 1 year and 4 years of experience. And just classifying patients according to their PIRAD score, you can see that if you have a PIRAD score of 4 or 5, then your treatment-free survival is much less than if you have a PIRAD score of 1, 2, or 3, and it didn't really matter what sort of experience you had. So if you look at this particular patient who's been on active surveillance for many years, here is a patient who has a PIRADS 1 score. Nothing is seen in the peripheral zone or in the transition zone. He's had his 6th year follow-up in 2015, and he's still fine. Whereas if you look at a patient like this, you can see that this was an obvious miss for the trust biopsy. You can see he had 1% of cause on the right, 5% on the left, only Gleason 3+3, but there's a large anterior tumor that has been missed. This patient had his active surveillance curtailed, but I haven't been able to find any follow-up on him recently. Now, this is an interesting patient in whom there is a lesion, and it's at the apex. He's got 3+3 in 2 cores, 10% on the right, 10% on the left. His right is clear. He's been on active surveillance for 6 years. So he would currently be called a PIRADS 4. And yes, he's continued active surveillance for a long time, but he was very borderline as far as our assessments were concerned. So this patient is a clear miss for active surveillance. He had 3+3, 1% of cause on the right and 20% of cause on the left, but he clearly has large volume T3A disease, and this is just the type of patient that we want to make sure that we pick up when we do multiparametric MRI for active surveillance. Here is another patient undergoing active surveillance. You can see 30% of cause on the left, no percentage of cause on the right. This large right apical lesion with extra capsular disease at the apex here has clearly been missed. Here it is again, clearly been missed. And this patient is clearly not suitable for active surveillance. The other thing one might ask is, can MRI help us to identify other subgroups that may be suitable for active surveillance? So these are patients, for example, with Gleason 3+3 disease who have a single risk factor that stops them being classified as low risk, so a PSA of greater than 10. What about pathologically larger volume T3 disease with bilateral involvement? What about patients with Gleason 3+4 disease? Well, let's look at these Gleason 3+4 disease patients. Now we know that Gleason 3+4 disease is included in some active surveillance protocols, but there is generally a lack of safety data regarding active surveillance strategies in these patients. And we are aware that there are biomarkers for oncologic safety are needed to identify this favorable subgroup of 3+4 disease who might actually benefit. One of these biomarkers could be imaging. So if you have a patient like this who has 3+4 disease in 4% of chips on a TURP but no visible lesion, that patient would be suitable for active, at least an initial trial of active surveillance, and in fact he's been on active surveillance for 2 years now. That strategy of saying that the absence of a dominant or index lesion on a multiparametric MRI has actually been validated. And here are a couple of papers that were published recently, both of them showing that the absence of an index lesion on a multiparametric MRI allows the identification of a small subgroup, and we know this is only about 10%, of 3+4 disease who are in fact potentially candidates for active surveillance because they turn out to be 3+3 disease at pathology. Now, what about men with only a PSA that's elevated and that's the only unfavorable characteristic? Well, it turns out that if you have PSA between 10 and 20 but you have a low PSA density as well, then your outcomes would be as good as patients with regular parameters for AS. So we may want to think about that kind of patient being undergoing an MRI before going on to an active surveillance program. So here is an example of somebody who came along, has 3+3 for active surveillance, but the PSA was greater than 20, in fact, in this particular instance. So puts him at high risk despite his biopsy cause only being 3+3. Now clearly he's at high risk, there's no doubt about it. He's got a big cancer sitting there in the front of the gland. But you can see how that thought process prompted an MRI, prompted the diagnosis of a tumor that was not known about anteriorly in the gland. The other thing I'd like to discuss is this question that I'm often asked. Can MRI substitute for an early end of first year reconfirmatory biopsy in active surveillance patients? There is actually no data to answer this particular question. But my conclusions from what I have read is that if you have 2 negative MRIs and you have had an observation period of greater than a year, then the negative predictive value for significant disease is likely to be high, and these patients can probably avoid a first-year biopsy. However, if you have a stable but positive MRI, even if there has been more than 1 year of follow-up on these patients, there is still a high probability of significant disease, and you cannot avoid a first-year biopsy for these patients. These are some of the thoughts that I've been able to gather from the literature as it currently stands. What about MRI in the follow-up of patients with active surveillance? So what about the role of MRI in helping to decide what happens while the tumor is being surveyed? Well, this is very interesting. If you have a small tumor or you have a normal appearing gland and nothing very much changes, then you should continue active surveillance. Sometimes abnormalities disappear, and this often happens with prostatitis, and you can see abnormalities appearing and disappearing over time. If you see a new lesion appear, but this lesion is diffuse, then this may be prostatitis. You should be thinking about a biopsy-directed action in this particular instance. If you see a new lesion, even if it is small, you should be careful about this. You can continue to watch if you like, but you should also consider re-evaluating the risks in this particular patient. Sometimes you'll see the same functional characteristics, but the lesion just gets larger. In other words, you see an increase in size, an increase in mass effect, but on the functional side it looks the same. Then you really ought to be reassessing or thinking about going off the program. So let me just show you an example. So here is a benign abnormality that's diffuse, that's bilateral, that's emerged between 2014 and 2015, and this is related to prostatitis, and you can see the placement of a bladder catheter between the two scans. If you look at this patient over here, you'll see this is the same patient that I showed you earlier, and we've now followed him to 2016. You can see that he doesn't change very much at all over time. We've got examinations from 2009 to 2012, and you can see, in fact, that in the fourth MRI scan there's an area of hyperemia that develops on the dynamic contrast enhanced study, and this is related to the third year biopsy. So this is clearly diffuse enhancement. But what about this patient here? You can see that over a year there is a slight but very subtle increase in size, not in the axial plane but in the coronal plane. Here to here we see a change, an increase in the size. The diffusion characteristics in fact don't change that much, but look what happens at the contrast enhancement. There is a dramatic change in contrast enhancement. This should prompt a re-evaluation of risk, and he underwent a Templar biopsy which showed a 3+4 cancer, underwent prostatectomy, and to our surprise he had a 4+5+3, and he had a T3A cancer. A complete surprise. Sometimes, as I've already said, a lesion will disappear. So here's a patient seen multiple times between 2008 and 2012, and this apical lesion, which all of us would call a cancer, with retraction of the capsule, suspicious for T3A disease, completely disappears across time. And we can look at that in the other plane just to confirm, in fact, that there is nothing here at the left apex in two planes. And one assumes that this was just mass-forming pancreatitis. So how does one then integrate and communicate this information to clinicians? Well, a structured reporting system using a prostate pictogram is necessary. There's no doubt about it. The PIRAD system, either version 1 or version 2, should be employed, An index lesion should be measured, at least a size if not a volume, and an ADC measurement should then be obtained. A recommendation should also be made for suitability to start or to continue active surveillance, and if things are changing, the biopsy strategy to be employed to investigate changes that have occurred. So here's a patient that we used in the clinic. Here are the examinations, and you can see that in fact the peripheral zone clears up over time, and the way we communicated that information was with a pictogram. Diffuse low signal change, a score of 11 out of 20. Here is the patient on a follow-up scan, a score of 8 out of 20. We see no change, no diffuse finding. We are now beginning to develop a Likert scale for changes visible on MRI. There are a couple of proposals that are on the table. One has a less of a dynamic range, and another proposal has more of a dynamic range, which may actually be too sensitive to picking up abnormalities. And both of these hopefully will be tested in prospective clinical trials to see which one of them is best at predicting biologic changes over time. So what does the NICE guideline say about MRI in active surveillance? In fact, it recommends it. It says that under enrollment for active surveillance, patients should undergo a multiparametric MRI, and if there's concerns on PSA changes, then the patient should be re-evaluated by MRI and or re-biopsy. So to conclude that section, we can show that MRI has the potential to increase the precision of patient selection at initial triage for active surveillance, helping to minimize the inclusion of higher risk patients. However, there are uncertainties about which combination of MRI features predict for treatment-free survival. We think that a PIRAD system by itself would probably be sufficient. We have a very strong inkling that the changing phenotype during the AS period should prompt additional targeted biopsies and the resampling to reassess the risk on these patients. We're not completely convinced that a change in the MRI itself should be a trigger for active treatment at this time. Clearly, the physician communication via structured pictorial report is key to the success for using multiparametric MRI in active surveillance patients. I'd be happy to take further questions at this point. Thank you very much for those questions. I'd now like to talk to you about the last section that I wanted to cover, which was the role of imaging for patients with advanced cancers. Now, we often hear these sorts of headlines that imaging plays a central role in the management of castrate-resistant prostate cancer because it helps to define the state, whether a patient has M0 disease or early M+ or polymetastatic disease, and that it's a game changer for many patients. But where is the evidence beyond these headlines? Well, if you look at the literature very carefully, you can find very good evidence of the impact on imaging on prostate cancer management in patients with advanced disease. And I've just laid these out on this slide. I just wanted to highlight one paper that was published in 2006 by Halabi. And this is this paper here, which shows that the anatomical location of prostate cancer is highly prognostic adding to prognostic models predicting overall survival of patients being treated with docetaxel. And I just wanted to pick up one image from a recent publication, the 2006 publication, which shows survival rates of patients with castrate-resistant prostate cancer, taking well over 10,000 patients, following them over many months. And it's quite clear to see that patients with lymph node metastases do better than patients with lung and liver disease, and that liver disease patients in particular do badly, and we know that thus liver disease patients often get treated with chemotherapy if they are fit. So can we conclude that because there's all this evidence that the current imaging tools are in fact fit for purpose? We already have very good evidence for this. Well, I would contest that current imaging in fact leads to poor confidence for assigning the clinical state and for predicting therapy benefits. Current imaging technologies such as bone scans and CT scans are unable to accurately predict who has metastatic disease. As a result, many patients in whom we think are M0 are in fact M+, and patients we think have oligometastatic disease have polymetastatic disease. We are also unable to be confident about which patient is not benefiting from treatment early after starting treatment, which means that we fail to rapidly detect primary and secondary treatment resistance, which impedes the patient's progress to alternative therapies. And I just wanted to give you one illustration that shows both points. So here is a patient with metastatic prostate cancer. You can see that this is a whole body diffusion scan, so part of a whole body MRI examination. We have retroperitoneal lymph nodes only, no bone metastases, so the bone scan is negative. Patient undergoes enzalutamide treatment at 13 weeks. We can see partial clearing of the retroperitoneal lymph nodes. The bone scan is still negative, so everything is completely consistent. And then at week 25, the MRI shows you a new finding. The bone scan shows you no new abnormality. How do we know that this is metastatic disease? Firstly, we have two previous comparator scans. Secondly, the MRI is a multiparametric study, which means that we can go back to the raw data and we can confirm that this lesion here is in fact a metastatic deposit, and that this lesion was not present previously. So this is the first point. The MRI performance for detection of bone disease is better than the bone scan. Now, is this a general phenomenon, or is it just this particular case? Well, what I thought I would do is put up this meta-analysis that was published a couple of years ago, comparing the MRI performance to the PET-CT performance using choline in this particular instance, compared to what is current state of use, which is bone scans. We can see that the performance of whole body MRI scans and PET scans on a per patient basis is much better than a bone scan. I don't think there's any doubt about this. So currently we should really be thinking about moving away from the bone scan as a method of assessing for the presence or detecting the presence of metastatic disease. So bone scans perform less well for disease detection, but what about for response assessment? Well, let's keep on looking at this patient. We can see that this is the scan that we just looked at. At week 25, So at week 37, what we notice is the whole body MRI scan shows, in fact, 5 lesions. These are just 4 of them. One is hidden and at the back, so I can't really show you this at the moment. But we see 2 lesions on the bone scan now. Now, is this disease progression at week 37? Well, if you use the Prostate Cancer Working Group 3 criteria, we need to wait at least another 8 weeks when we need to confirm the presence of the same lesions that have just been seen. So we wait to week 49. You can see the PSA at last increases. We see not only do we confirm those 2 lesions, but we actually see many more lesions. So this is the point at which the patient is said to have progressed. So at week 49, the patient is confirmed to be progression. What was the real date of progression? Week 25. So he had 24 weeks of treatment that were not benefiting him. For what? Why? Because the bone scan technology was the impediment with this. Now, many of you will say, but bone scans are always done with CT scans, so that makes things okay. Well, it does for the soft tissue disease, but you really need to be very careful about using CT scans for the assessment of bone. Now, we know that there are several morphological patterns, CT patterns for in castrate-resistant prostate cancer, and here are the prevalences of some of these patterns, and we know that these patterns are biologically meaningful. So we know that if you get an osteoblastic metastasis, that this is due to Wnt1 upregulation resulting in osteoblastic recruitment, and then the laying down of new bone, which then ossifies resulting in these sclerotic deposits. But look at the same patient a year later, in a slightly different site, but a year later. What we see is an osteolytic pattern in this particular instance. So this patient switched from an osteoblastic pattern to an osteolytic pattern, and that osteolysis is due to osteoclastic recruitment and activation. And these are some of the molecular mechanisms that results in this osteolytic pattern developing. Now, clearly there is detail behind this image which I'm unable to discuss with you today, but as a broad brush, one must realize that early on patients present with osteoblastic lesions. Later on, these may convert to an osteolytic pattern, which indicates a more aggressive form of prostate cancer. We know that CT scans can help to sort out the false positives of the bone scans in something called SPECT-CT. And here's an example of a patient with uptake in the lower lumbar spine, and clearly this is due to degenerative disc disease as depicted on the CT scan. We also have to remember that sclerotic or blastic lesions are better seen than infiltrative lesions, as a result of which up to 30% of lesions are missed or their volume is underestimated. And I just thought I'd show you one example of this. So here's the patient with retroperitoneal lymph nodes on this diffusion scan, and again we will come back to what the diffusion scan shows us and how that technology works in a few minutes. But you can see that there is so much disease. There is very little in the way of normal marrow remaining on the morphological MRI sequences, on the diffusion images. But if you were to look at the CT scans, that completely underestimates the amount of disease that's there. You can see it, but it completely underestimates the amount of disease that is there. Now, one of the biggest problems with CT scans is that osteosclerotic progression and osteosclerotic response are difficult to distinguish. In other words, progression and regression can sometimes look very similar. So here's a patient with a bone scan. Again, we followed the patient for about a year, December 2011 to November 2012. We can see that there is a decrease in the amount of activity in the bone scan over time, clearly indicating that the patient is responding to enzalutamide treatment. If we were to look at the patient's bone scan, what you would notice is the emergence of a new lesion. Is this improved visibility a function of progression, i.e. new disease, or is this due to healing? Well, clearly there was a lesion there before. It's just well marginated. It's dense. This is in fact healing. So you can see how this lesion, which was reported as progression, in fact represents healing. Now, look at this patient. This patient has something called sclerotic progression. You can see two scans, February and December 2014. The PSA clearly goes up. The patient is increasingly symptomatic. He has bone pain. He has nausea. He's got vertebral collapse. But if you were to look at the bones, you would see increasing sclerosis. Remember, increasing sclerosis and could be due to progression, could be due to healing. Sometimes they are very difficult to distinguish. So now that you know the limitations for bone, that you can only really look at progression criteria with CT scans and bone scans, can you do better in the clinic today? The answer is yes, you can. In fact, imaging technology, there are several imaging technologies that let you look at different aspects of the bone to try to work out what is going on. And what I wanted to talk to you about in the next few minutes was MRI scanning. Now, it turns out you can tune an MRI scanner to be sensitive to different components within the marrow. So you can tune it to be sensitive to the presence of cellular and water content, or to the trabecular bone, or to the vascularization, or to the trabecular density, or the cellular density, or fat content. And what I wanted to do was to show you that in fact, just by taking three components, you can make a multiparametric technique that you can do very easily in the clinic. And here is an example of a short MRI protocol consisting of one functional technique, which is on the right hand side, which is the diffusion technique, and a morphological technique, which you see on the left hand side. And that takes less than 30 minutes of table time. If you decide to use a more comprehensive approach for response assessments, for example, then that would take 45 minutes. So very workable in today's environment. Now, we have well-published criteria on what constitutes disease progression. So the appearance of diffuse disease, the appearance of focal disease constitutes progression. Here is an example of something like that. So here's a patient whose PSA falls between January and October, yet the patient is progressing. So we can see the presence of new lesions, for example, in the vertebral bodies. This is progression on enzalutamide treatment. Here's the same patient looking at the whole body scan. We can see many more lesions within the skeleton, and in fact you'll notice the emergence of a adrenal lesion. This is in fact just adrenal hyperplasia because you're affecting the androgen axis. Regression of abnormalities can then equate to the presence of response. Interesting. For the first time, I've talked to you about imaging used to assess response to treatment in the bone marrow. And it's an interesting phenomenon that has utility, I think, in prostate cancer. Now, here's a patient we have been treating him with, as you can see, initially docetaxel and then cabazitaxel. And one would notice is that on the morphological sequences we can see a reduction in the size of the lesion, which in fact becomes slightly darker. That represents some regression, but we've got a scar here. New disease is manifest by the presence of new abnormalities in previously uninvolved bone, but again, these lesions also lead to sclerosis. And I just wanted to give you an example, a more extreme example of that. So here's a patient, the same patient that I showed you previously on 2 occasions before and after 4 cycles of docetaxel. You can see on the T1 sequence there seems to be even some disease progression. On the T2 you can see some relief of the cord compression, but on the diffusion sequence what we notice is a dramatic change in the signal intensity. Now, why does that happen? Why do we see this dramatic reduction in the signal intensity, yet apparently on the T1 sequence it looks a lot worse? This is the point at which we really need to start to talk about what diffusion imaging is. Diffusion imaging is a technique that looks at the microscopic motion of water within tissues. So a phenomenon that's occurring at a nanometer and a micrometer scale, averaged up at the level of a pixel, which is in the millimeter range. And this is just shown as a cartoon, and clearly what you have to remember is that if you have a loose glandular tissue, then the water will be able to move a lot more. If you have a tightly packed tissue, then the water will move less. Using diffusion imaging, it is possible to measure that motion in a unit called the apparent diffusion coefficient, which is called the ADC value, which has a unit of micrometer squared per second, which is the net diffusivity of a lesion. Now, if you look at that same patient that I showed you before, here is the ADC histogram. If we look at the histogram, one can see a dramatic increase in the mobility of the water, with the ADC histogram shifting to the right side, indicating an excellent therapeutic response, and that shift is related to reduction in the cellularity of the lesions. So, what should you be doing in the clinic? Well, in the clinic, for metastasis detection, we are convinced that bone scans and CT scans do not provide robust enough evidence for ruling in and ruling out disease, despite the fact that the guidelines say that this is what you should be doing. We are not convinced. We think that a more sensitive modality should be used, preferably a single modality that detects both bone and soft tissue disease. We think that whole body MRI could replace the use of combined CT and bone scans. Other alternatives would be something like fluorocholine, sodium fluoride PET, or even PSMA PET. So just to give you some examples of these other technologies, so here's a whole body MRI scan on the same patient, and this is the choline PET scan. you can see a number of lymph nodes being projected over the pelvis. These are in fact normal nodes, but there are 2 abnormal lymph nodes on the choline scan, which are very much visualized when you do the cross-sectional image. So here is a lymph node in the left internal iliac region that was pathologic. Here it is on the MRI scan, but one of my colleagues didn't call it, so we are going to call that a false negative for the MRI, but a true positive for the colon. It also turns out that for the bone marrow, the MRI is slightly better than the choline map, and this is probably related to the intrinsic high cellularity of the bone marrow on a choline map. So here's a lesion that is negative on the fluorocholine map, but is very much positive on the MRI scan. Lastly, some of you will be aware of this, that gallium PSMA is the new kid on the block and can be very successful at detecting the presence of metastases. And you can see this patient's PSA is only 0.25 3 months after surgery, and he has a lesion in the rib which is not detectable by any other means. So what do the guidelines say? Well, the guidelines have still not caught up. All of them still emphasize the use of CT and bone scans, no matter where the patient is on their pathway. New diagnosis for biochemical recurrence, or when there is CRPC, M0 CRPC. This is going to have to change. What about in the treatment monitoring arena? Well, again here the emphasis is very much on the use of bone scans and CT scans, as emphasized by the EUA guidelines of 2014. The St. Gallen International Consensus Panel also emphasized CT scans and bone scans, and for clinical trials still we find CT scans and bone scans being recommended. But this is about to change. We can see the new METRADS-P guidelines saying that MRI at baseline and after every 2 cycles, depending on whether you're on clinical trials or whether you're in clinical practice, should be considered. The METRADS-P is the new standard for whole body MRI scanning in advanced prostate cancer. It's a standard that advises on how to standardize imaging on a variety of machine platforms, interpretation guidelines, performer reporting, and data collection. Watch out for these new guidelines when they are published later on this year, because they have the opportunity to change how we do clinical trials and in clinical practice. So many of you will be wondering why you should bother. You should bother because of this. We now know that there are lots of life-prolonging treatments available in advanced prostate cancer, and we see this increasing in the future. Currently, the methods you use for bone disease are all based on progression. So patients either have progression or no progression, and that's how that's communicated to oncologists. With the new types of imaging that I'm talking about, and the use of serum markers and PSA, we will be able to change this now and treat bone disease very much the same as we treat soft tissue disease. So in soft tissue disease we have 3 categories: stable, response, or progression, and we should be able to do the same thing with bone disease also. By changing this categorization from progression, no progression, to 3 categories, we hope to influence oncologic thinking regarding treatment with drugs that have novel or targeted mechanisms of action, and that will have consequences on what is observed. Thank you very much. I'd be happy to take further questions on this topic.